Let's get underway. So, welcome everybody to this webinar. I'm very, very pleased to have with us this evening in the UK with me, this afternoon in the US, but Dr. Kathrin LaFaver from the University of Louisville. Thank you. I was having a senior moment then.
That's okay.
But a real pleasure to have you here, Kathrin. So,
Having me.
please introduce yourself to our attendees and describe a little bit about where you're working at the moment and what that work involves.
Sure. So yeah, I'm a director of the Movement Center here at University of Louisville. And I've been interested in functional movement disorder in particular for quite a bit because I did my residency training at Mayo Clinic in Minnesota, and you may know that they have an outpatient treatment program for FMD, and so that's how I became interested in this. And then I did some fellowship training with Mark Hallett up at the NIH in Bethesda. And so since 2013, I've taken the position here in Louisville, and we started a treatment program for functional disorders in 2014. So I've been involved with it for quite a bit now.
Okay, and one of the main initiatives that you now very currently known with, of course, is the MORE program,
Yeah.
which has been tremendously successful for you. Tell people about what the MORE program is and how that came into fruition.
Yeah, so as you probably know, and everyone knows, but there really is a lack of resources for functional movement disorders. And not only do people have really trouble getting diagnosed, finding a practitioner, a neurologist or other healthcare practitioner who's really familiar with the diagnosis, who's willing to take on their care, but then there's really lack in accessing treatment. And so yeah, I was interested in researching FMD, but most of all, I wanted to offer people hope and help, most practically. And so when we try to design a treatment intervention, so first of all, I should mention there's really not a gold standard. There's no treatment like a society treatment guidelines out there, and there's kind of a paucity or lack of randomized controlled studies to really know about what works best. So I sort of went off the Mayo program, and so at Mayo Clinic, they do an outpatient treatment program for 5 days, very heavily focused on physical occupational therapy. And so I had seen that work. However, I also personally felt that it might be helpful to have the psychology component a bit stronger focused and not so much, our program is just a week, so we're not going to deep and go into all the details of childhood, and possible issues there. But we're kind of more a cognitive behavioral approach and focused supportive therapy, dealing with how can we deal with problems in our life, just even adapting to the diagnosis, etc. So it's really, so our program is inpatient for 1 week. Usually people get admitted on a Sunday, get discharged on Saturday, and during the week they have 3 hours per day, physical, occupational, and speech therapy if needed, and then 1 hour with a psychologist. And so, yeah, we've been doing it now for almost 3 years, and I wish we could take more patients, but maybe they'll talk about it in a second. It's quite challenging here with the insurances, etc. So. We're kind of struggling and to make it work ideally. So I hope there's going to be a positive change in the future.
Yeah, I was going to ask about that. Obviously, the fact that you created this program, and it certainly does seem to get a lot of interest. I mean, how big is the demand, and how are you able to try and satisfy that?
Yes, it's a good question because I know the program at Mayo for a while was booked out for over a year, so they like literally waitlisted people for an entire year, which is pretty not so useful to have to wait that long for treatment. So our operation here isn't terribly big. It's just yeah, we're located in a rehab hospital. But we have decided that we would not directly admit patient in the program, but we would see them first in the clinic because we really want to get to know them. Want to make sure we agree with the diagnosis. We have a assessment from the physical therapist and psychologist, and educate about the program and really make sure this is going to be a good fit before we get people in a program. So we currently have a capacity to, we do a clinic once a month and basically see 3 patients in that clinic. So, and then that's usually the patients that we admit inpatient. So it's essentially 3 patients per month. And
Right.
we could certainly see more, but again, it's a bit of a capacity
Yeah.
issue here, and then unfortunately it takes quite an effort from the part of our admission coordinator to actually get the admission approved. So unfortunately I wish it was just a smoother process, and I'm always a bit jealous when I hear some of my colleagues here in the UK talk about a 3-week or 3-month admission and, and all these types of things. So that certainly would not be feasible here, I would think, is even for the 1-week admission, we get a lot of pushback because the insurances say, well, why can't this be done locally where a patient lives, and outpatient, and et cetera. And, obviously that would be ideal, but at least at the current time, there's just a lot of therapists who are just not even familiar with the diagnosis. And certainly physical therapy is not physical therapy. I mean, it really only works if someone really knows, is very familiar with the diagnosis, with techniques that work for FND. And so that's really part of the issue why people come to our center before more specialized care.
Yeah, yeah. And just on that topic, obviously the fact that it's so difficult getting centers out throughout the rest of the US. But I know that you've run an education program for professionals, and you did do a weekend workshop back in October. How is that process working out, getting the message out and getting these techniques out to that community?
Yeah, so that was very exciting. We decided to do this workshop and didn't really know what the interest would be, and we had 60 people. And what was even more exciting is that these people came from 7 different states and Canada. So there's actually an enormous interest out there by professionals to learn more about functional movement disorders. So from what I have heard, so we set up a sort of an official certification process or anything like that. We're not really planning, I guess, to franchise it or something like that. But I've heard from Denver that they are working on offering a adult as well as a pediatric program, which would certainly be very very needed. Our group here, so not me personally, but one of our pediatric rehab doctors and a pediatric neurologist are hopefully also going to be able to offer a PEDS program later this year. So I think that would be very exciting because we get quite a few requests from mostly teenagers, and currently we have age limit around 17, 18 for the program we currently offer. So I think there's a lot of interest. I think the whole reimbursement issue is unfortunately getting a little bit tricky, and just with the current administration and some changes in the healthcare market, it's so that's mostly the reason why we can't really just offer it more, because it just takes a lot of our resources to, we see these free patients a month and then going kind of back and forth with these insurances and really, doing an appeal, getting him finally admitted. It takes a lot of effort, and we're happy to do it, but it's just, it's not all we can do. So we have to take care of, other things too. So that's the reason why we have it fairly small, or have kept it fairly small.
Yeah, no, totally understand. I'm just going to say, by the way, pardon the barking dog that is sat here with me in my my study. But if you have any questions, please ask the questions in the chat or through the Q&A. For those on Facebook, just put your questions in the comments, and we'll get to them as soon as we can. But Kathrin, just picking up on what you were saying there as well, for patients who are struggling and obviously trying to get access to services, what's the story that we can tell them at the moment?
Yeah, well, I think I think in any case, finding providers locally is really important, because even for those patients who come to us, to Kentucky, we sometimes see very dramatic improvement within the week. But even so, ultimately when you get home, most of the time it is advisable to continue to some extent, either therapy or, at least visits with a local provider who can really take over the care, because it's not really too feasible to continue following with us if you're not living close to where we are. So well, you guys have started this provider directory, so hopefully I'm kind of hopeful that this will be more populated in the near future, and hopefully you can actually access that and find more providers locally wherever you may live, who have an interest in functional disorders. And I'm hopeful that the American Academy of Neurology meeting is actually coming up next week in LA. And I think that'll be another opportunity again for me and others to spread the word and really make people aware that we need to step up as a step off the plate as neurologists, and not abandon patients, and not, because I hear this over and over again, that people get diagnosed and then essentially told, well, nothing is wrong, this is nothing serious, you don't need to come see me back, and get essentially left in the rain.
Yeah.
And hopefully that's going to happen less and less. So actually one of the mornings at the AN meeting is always devoted to controversial topics in neurology, and one of the topics this year is, should patients with functional neurologic disorders be taken care of by a neurologist as a primary, I might not say this exactly right, but so that is the issue that is discussed, which I think, it's good to be out in the open. In my opinion, obviously there's not really a question about it, but yes, we should take care of patients. But since so many people feel differently, I think it's at least good to bring that conversation out in the open and be sort of clear about it, and hopefully sway a lot of people to, like I said, step up to the plate and not abandon patients.
Yeah, that and certainly is an experience that obviously a lot of people within our Facebook community and our private groups certainly do have plenty of evidence to that, where they do feel, oh, you've now got your diagnosis, go and read this website, and that's about all you can do. So it is interesting, the fact that there is this movement, and certainly from the conference that John Stone ran last year in Edinburgh, with around 500 neurologists coming to that, which was fantastic. So I think the feeling is much more positive that neurology is the right umbrella, I suppose, that this rightfully sits under. But there is still that, if you look at the DSM, the diagnosis is still putting it firmly in the mental health camp. And we know that psychiatry has got a lot still to offer in obviously solving problems for patients and making them better, which I guess brings us back to, your program is all about, combining that, in terms of physiotherapy and psychiatry. For those patients that are having difficulty in getting support, and they wanted to create their own network because that's all that they can do, how would they go about trying to achieve the best support circle for themselves with professionals? How did they choose the right neurologist? How did they choose the right psychiatrist?
Well, I think with choosing a neurologist, I think it's going to be pretty evident after receiving the diagnosis, if this is going to be a person who is going to take sort of an interest and an ownership in helping with the problem or not. And I think that relationship needs to be there, right? Because ultimately the patient is not going to benefit if you don't want to see someone where you feel continuously sort of dismissed or not taken serious or whatever it is. So again, I'm hopeful that, and I do see that, but especially more and more of the younger neurologists and current trainees are getting, in more appropriate ways, and not sort of along the lines of, oh gosh, don't worry about most patients,
Yeah.
get them out of the door. Unfortunately, I think that would be really the lingo that was used with trainees to kind of not use resources on patients who don't have quote unquote real neurologic disease. And I think that thinking is definitely shifting. So yeah, I mean, for patients looking for sort of their own treatment team, I think working with physical therapists who again have an interest in helping. So if it is a person who is willing, if they have not really heard about it much, or there is a lot of literature out there now, and so Glenn Nielsen and many others have certainly collaborated and written sort of consensus statements for physical therapy. And so I think for people who are interested in helping people, you can certainly find, or maybe even work with a therapist who can kind of educate themselves and then kind of work that way. So our course, we're not going to offer one this year. We're kind of planning to do it again next year, but our course is still available online. So what we often do, if patients do our program here and they might be better but not quite yet where they want to be, so we encourage people to find a provider locally who can, our course, it's not very expensive. We purposefully held the cost actually very low. So you can still take it online, and the cost is $100 for, or $99 for MDs, and I think it's $49 for any other healthcare provider. So the cost shouldn't be really prohibitive. So if they have a physical therapist, they can watch our materials, and there's other papers out there from Glenn Nielsen and others, and maybe educate themselves, with some of that training, being able to help people, regardless of where they are.
Yeah, yeah. Question here from Gwen. She's just asked, and this is in relation to accessing services with yourselves, but are your patients seen based on severity or based on the time that they contact you?
So we have a pretty well-outlined referral process. We actually do have a website from our clinic portal, and that kind of explains the program, and then has a referral form. So we do require now referral from a physician, ideally from a neurologist, just to make sure that the diagnosis was indeed made, that we do are dealing really with a functional movement disorder. And then we have a couple criteria. We just want to make sure that so yes, but actually the symptoms need to be severe enough to actually justify inpatient treatment. And again, that's mostly an insurance issue. So we try to actually, our coordinator would actually call the patient and we review the records. And again, typically they need to be severe enough to justify an inpatient stay. So if someone, say, just has tremor in a hand, but probably wouldn't qualify for an inpatient treatment. So that's kind of really the main criteria. We look at the symptom. We do look at the symptom severity, and then we look at some inclusion criteria. So if someone, for example, has very severe depression with suicidality, that wouldn't be a good fit, at least at that time, to come for just sort of a 1-week boot camp treatment approach. So we're kind of just looking for a couple things that might not be a good time for that person to do that treatment. But otherwise, we're fairly open. I mean, we don't have a lot of restrictions. So yeah, it's mostly, obviously the time the referral is sent, but then also the severity of the symptoms. So yes.
Yeah, and I'm going to encourage people, please keep your questions coming, but whilst waiting for some more questions, I'll ask you this, based on the people have come through, and I've seen some of the materials that you presented at the October session, and you certainly had a wide range of people. But one of the questions, the most common questions that we do see, is for people who have suffered with FND for a long while. What are the prospects of getting any significant improvement? What's been your experience in the practice?
Yeah, so it's pretty interesting because so we did look back after the first 2 years. So we had about close to 60 patients, and we kind of looked like what is predictive of a good versus a not so good outcome. And interestingly, at that time, duration of symptoms did not correlate with the outcome, which actually was very surprising to me because it's definitely in the literature, and you can sort of read it. If you have your symptoms for more than a year, the prognosis goes down, which is kind of scary because 1 year is not a long time. By the time you get a diagnosis, see a physician, I mean, this 1 year's mark is gonna, come around pretty soon. And so I can definitely say that that's not what we've seen. I generally think if people have more issues with depression, anxiety to a severe degree, or other kind of severe issues in their life that are really having a strong impact on their overall quality of life, they might not be in a good position at that point to really make the best improvement. And I think there could be a number of reasons for that, but sometimes that's sort of what we do see. So if someone does have a strong history of psychiatric problems, then it's sometimes a little bit difficult or more takes more time for
Yeah.
to and that's not too surprising either, that you wouldn't see that very quick turnaround.
Yeah, it's interesting. I'm just looking over at Facebook, and Carmen has made a comment here, and I think this is quite interesting, and I'm interested in your perspective on this. But you've been diagnosed with ME for 12 years, with seizures and severe mental health issues as well. Her difficulties, I mean, she's living in a part of the UK, Cornwall, which is a long way from London, and is always difficult trying to get professionals in that region. And I know there's many parts of the US that suffer the same thing. But with somebody experiencing that sort of range of comorbidity, I suppose we could call it, how does that impact a professional that's trying to treat FND and with somebody with those other issues? Is a conflict between the two?
So I wouldn't necessarily say a conflict, but yeah, I think sometimes the more symptoms are present, you know, it, it, it's, I wish I kind of had a better handle on kind of knowing exactly what helps a particular person, because it's not really as straightforward as you think it would be. And I'm always very perplexed almost. And of course, I'm very excited when someone does have this very dramatic improvement, right? And then by the end of a week, I ask them, well, what helped you this week? What really was it that allowed you to get better? What was the most helpful? And usually people tell me these kind of pretty straightforward things like, gosh, a therapist really showed me how to put one foot in front of each other. And so, it's kind of really hard to manualize that because, it's just kind of difficult. I think again, I mean, I think the relaxation part of the therapy and kind of, again, getting this body in this relaxed state where these movements don't kind of overtake and kind of allow the person to sort of get back in charge of the movements. I think that is very important to be able to kind of access that state. And it sounds almost a little bit esoteric because, again, some people, the deep breathing exercises are the most helpful. For other people, it's different types of relaxation techniques, or just walking, and that active walking sort of frees up some some different connections, but it's a little bit hard to really know. And so on the flip side, kind of the more symptoms are present, it can kind of get a bit tricky. And sometimes what I've seen is that the movements get better, but then the person is still left with quite severe pain and bodily pain, and whether that is more classified as fibromyalgia or different types of pain. So it can be tricky to kind of, if you have a complex of symptoms, like kind of getting rid of everything. And again, sometimes once one symptoms gets better, everything else sort of follows along with it, and sometimes that's not so much the case. And so we're trying to understand this better. I mean, we've kind of put in some grants to hopefully study FND better and find some biomarkers. So our hope is that we could, before treatment, do get some blood samples, check hormone levels, check inflammation markers, check other kind of things that might be potential markers or abnormal in FMD, and see if different therapies can kind of impact that in a different fashion. But I think it's a bit of a knowledge gap to this point to really know what works the best, and why does it work.
Yeah, yeah. Is the use of functional MRIs helping at all in identifying causes for FMD?
Yeah, so the group with Mark Hallett has done some fMRI research and had some interesting findings of looking at both resting state and task MRI. We have done some studies also. We're still looking to do more. So we have had this preliminary study with 9 subjects and had them do a task under an MRI scanner, which was basically a push button task. And it was pretty striking, but even with just looking at 9 people, we saw quite a difference in the motor performance before and after treatment. And such as that after treatment, the movements were more coming, or regions in the brain were activated that have stronger to do with motor planning. So without kind of overreaching too much, it kind of suggested that um, the person after treatment has maybe more access to purposeful or conscious movement planning. So in a way, it was pretty exciting to see that, and to really see that a change in brain activation patterns can happen after this 1 week of treatment. So it's something is really going on, that or the brain is kind of
Yeah.
organizing movement differently. So that's pretty exciting. But it's not used at this point as a diagnostic modality. So I don't think we would be able to do that.
Yeah, no, but I think what's fascinating, isn't it, is because obviously what we're concerned about a, a number of things within FND, from diagnosis through to treatment and so on. But the fact that you've got some way then of measuring with a functional MRI to say, okay, well, because we've now done this week's worth of work and we can see the difference evidence, that's amazing, because that's kind of the proof that, especially for insurance companies and so on, but just for everybody to understand that this program and these techniques will actually make a difference.
Yeah, I hope so. I mean, I think again, I think they need to show this in a larger number of people, and we would also ideally show the more long-term outcomes. It's a little bit challenging. About 50% of our patients currently are from out of state. So, without having funding, it's kind of difficult to bring everyone back after 6 months, because, the people here come from several states away. So it's kind of, not just a small car ride, but it's kind of expensive for people to travel. So we don't have it set up currently, but we actually see people back in person. We usually follow up with a survey after 6 months to kind of check in and see where they're at. But that has been, not ideal. But we just because mostly of geographic distance, can't really continue to follow, and maybe do another follow-up scan at a longer time interval.
Yeah, yeah. Question here from Tracy regarding the functional MRIs. She's asked, does the MRI then prove that there is a dysfunction in the brain?
Yeah, so the study that we did was basically comparing the thin per subject comparison. So we didn't compare people with FMD against healthy controls, but we actually compared the person against themselves, so before and after treatment. So it's a more of an indirect kind of answer to the problem as far as abnormal brain structure, but yeah, or abnormal brain function. But yeah, I think the fact that we see that, again, the movement patterns are accessed very differently after treatment is, and so before treatment, we saw more kind of direct kind of movement structures like basal ganglia and kind of movements that more kind of um, inst- instinctual movements, that kind of areas that have more to do with that. And again, after the treatment, there was more prefrontal cortex, more kind of areas involved with kind of thought process. So again, I think there's definitely more work to be done, but it was definitely some interesting initial findings.
Yeah. Who else is doing work with functional MRIs? Pamela's just asked, are they available in the UK? And I know that there have been some use, but it's fairly low key in the use at the moment because it's expensive technology.
Yeah, but again, I mean, we don't do it for diagnostic purpose. We do it for research purpose. I know the Mark Hallett's group at the NIH is also doing imaging research, and David Perez at Massachusetts General in Boston is doing quite a bit of imaging research. I'm not exactly sure who's doing research in the UK on imaging.
Yeah, yeah. Another question that comes to mind, talking about obviously successful outcomes, which is always great to hear. But what are the examples where things haven't been as successful for people? Is there a trend that you've seen where people haven't made the progress that you would expected them to do?
Yeah, so sometimes it feel like I hinted a little bit before. If there's sort of ongoing, significant, unresolved issues to kind of more broadly thinking, I think to some extent things kind of have to fall into place for a person to really get better. And so by that I mean, obviously someone has to be kind of motivated to participate in the therapy, to put in the work. And again, it's sort of almost like going on a mind exploration, right? Because the therapists are really just the guides. We kind of can't make this therapy work for someone. It is really finding the right treatment, and to some extent it is very individual. And it's almost kind of like, with the brain computer interface machines now that are available for all kinds of things, and you need to kind of learn. I've never done this, but I just read about and heard about it. Like you kind of need to, you learn how to control the computer screen with just your eye movements. You have to come up with some of these crazy techniques to figure out how to make it work. And so it's a little bit similar, that again, what we're trying to do is these movements that are not perceived to be under control, to bring them back under control. And again, people kind of just, I always ask people who are able to do it successfully, well, how do you do it now? And again, they just tell me things like, I learned to tell myself stop, and it's just, it sounds so simple, and I wish I wish it was so simple. But it's just really interesting how people, ultimately end up describing what works for them. And so conversely, some of the patients where it doesn't work, sometimes what happened is that the person actually has made tremendous progress, and then something else happens. For example, we had a patient who then got a cancer diagnosis, and things sort of fell apart under enormous amount of stress, etc. And then very slowly we've been able to help pick up and make some gains again. But so that type of thing can certainly happen, that someone is able to make improvement, and then a very stressful situation or event might arise, and there might be a kind of a relapse. um, there have been, not very many, but there have been a few patients where we just didn't see much improvement during the week at all. And it's difficult to understand what in the individual case, why it wasn't helpful. um, the question is always, well, did we miss something? Was there something else going on? And we had one patient where we ultimately suspected there might be a different neurologic disorder. It's also the reason why we really try to really screen people very well. And in fact, we had a patient recently who was sent for functional dystonia, and then after we evaluated her, we actually didn't agree, and we kind of thought she actually should be treated, with botulinum toxin for dystonia, and we did not think it was functional. So again, I mean, it's always kind of a tricky part because, of course, there is not sort of a gold standard in making the diagnosis. There's not kind of a 100% test. So sometimes when people do not improve, so it's always kind of a time to maybe reevaluate the diagnosis as well, and then make sure we haven't missed something else. If you don't think that that is the case and we haven't missed something else, again, it there might be different reasons why a person is not improving. And it's certainly, it's kind of difficult because sometimes, especially when people come here and travel here, they have, of course, put a lot of hope in this. And so it's quite disappointing if you do not see the improvement that you expect. So I always tell people, oh, gosh, it's not your fault. I mean, people have to come and put in effort. And so what has been kind of gratifying to see in some patients, that after they leave, they continue practicing, and it has sort of clicked for some people at a later stage, and they were still able to make gains or make improvements. But again, I think it's another area of research that really needs to be done to figure out, why some people do not respond to the treatments we currently have, and maybe how we could help otherwise. And there's some interest in transmagnetic brain stimulation, or TMS, and there's a group in Paris who has explored that a little bit. And I know there's some other researchers who are interested or thinking about it, at least. And that could be, so with TMS you can modulate neural pathways through magnetic stimulation, and it's not a permanent thing you do. It's a therapy that's currently used for depression, for example, not for, not as a first line treatment, but for refractory depression, and can be helpful. And so I would imagine that if we find the right networks to stimulate, that something like TMS could be a means of treatment in the future for people who don't respond to physical therapy, for example.
Okay, okay. We've got a couple more questions that have just come through the chat. Stephanie has asked, do you find that some patients, even without huge stressors, that FND can fluctuate and follow a relapsing remitting type model similar to MS, but with different cycle lengths, example, hours, days, a week?
Yeah, that's interesting. I mean, certainly FMD can be episodic, and of course, kind of on the one side of a spectrum would be non-epileptic attack disorder, which is very episodic. Um, so yeah, we certainly do see fluctuations. I haven't. I mean, usually most people will say more kind of a stress-related pattern, sort of, gosh, yeah, I was going through a lot, and then my husband asked me to do this, and that really kicked me over the edge. So I mean, generally that's more of the common thing that I hear. But sometimes people are not always good at picking up the stress, or stress is also sometimes a bit of a misnomer, or people kind of, don't respond well to that, because what we kind of sometimes find is that there was a stressful situation maybe 1 or 2 years back, and now they feel there's actually no stress at all. Like, for example, someone retired because they had a very stressful job, or someone went through a divorce and now is actually remarried and very happy. And so we have seen that type of pattern in some patients. And so it's not so clear what is going on. And, I mean, one can speculate, well, maybe that toxic work environment the person had for 20 years kind of, it's just not so easy to just shake it off, and has left more permanent marks. And it's not just so easy as to say, oh, well, you're retired now, everything's fine. And so, but it would be, again, it would be necessary to really study that, for example, brain imaging, to really be more certain about what is going on, and why it's not always such a simple equation. Oh, stress, FMD, no stress, FMD symptoms get better. It's certainly not always so straightforward.
Yeah, yeah. Okay. Um, Tracy's got a question here on Facebook. If a patient has FMD, do you find they may also have issues with the autonomic nervous system?
Yeah, that's definitely a very good question also. And again, I think we're definitely learning about this. And I know there's someone in the UK who is, or has published, or is in the process of publishing a bladder dysfunction in FMD. So I think we used to think, gosh, if someone has a lot of autonomic dysfunction, it can't be FMD, because that shouldn't kind of affect the nervous system in that way. But I think we have found that people actually do experience GI abnormalities are very common, and whether it is constipation, diarrhea, and the bladder symptoms are surprisingly common also. So bladder urgency, kind of a feeling not being able to empty, or the opposite, or even incontinence can happen. And I think that's a bit of a shift in thinking that this can be part of FMD.
Yeah, no, we did an interview just recently with Ingrid Hertzer, who's
Yeah, I think that's what I'm thinking about. Yeah.
which, if anybody's interested, is on our YouTube channel, so they can go and look at it later. And I know we're getting close to the end now. We do need to wrap up. So if anybody has got any last minute questions, just quickly fire them through. Beverly's got a question here. This relates to our discussion about the insurances. She said, is this a barrier for treatment in the US? Is anyone finding a way or method to get the insurance okay? So are you aware of anything that particularly works well with the insurance companies?
Well, so to be perfectly honest, but what often happens is that the insurance will initially deny the stay, and usually they say it's not medically necessary to be an inpatient. And then we usually do an appeal. I often have to talk to the medical director on the phone directly, so to do like what's called a peer-to-peer review, and just kind of explain FMD, explain the treatment. So it's really, and these are not necessarily rehab doctors or neurologists. They might be ER physicians or orthopedic surgeons, or who don't really have a good understanding of this. And so it's quite variable. So unfortunately, it sometimes really boils down of me being able to convince this other person, and that other person being receptive. And so it's a bit it shouldn't be so subjective, right?
Yeah.
Because well, just yesterday I had a reviewer who was actually a physiatrist, and then he was very open, and he was actually very interested. And then he was like, yes, I'm going to approve that week, and make sure you have good aftercare afterwards. And I was like, oh. It's like, can you just write a letter and I can use it for everyone? But so unfortunately, it's I wish it was there was a more standardized. It was easier to get it more standardized approval. And again, we're just doing a week. I mean, sometimes I'm using sort of a cost argument, right? I mean, you pay for 1 week inpatient stay, and you can really help that person, and also save money for the insurance down the line if this person is less reliant on healthcare visits in after treatment. But yeah, it's again, I don't know how it is in the UK, but it is a problem here.
Yeah, I mean, we are fortunate. We've got the public health system, which most of our professionals are working in. But I know that it's a challenge elsewhere in other parts of the world. So um, the last question that's come in, I don't know if you'll know the answer to this one, but Katie has asked, do you find that the UK has more FND diagnosis than the USA?
So yeah, I'm not sure if anyone has done a comparison. We're actually planning to do a comparison study looking not just at the US and UK, but also some other countries and maybe some other continents like Asia or Africa, and because this is really a worldwide issue. Although I do suspect there are cultural differences. So with the US and UK, I wouldn't suspect that it is dramatically different. But I haven't actually seen a comparison published on that.
Yeah. Okay. Well, I think that's a great place for us to wrap up. Really appreciate your time this afternoon. It's been great talking to you. We wish you well for the next 12 months in pushing forward with the more program and getting more participants
More.
working with you. Yeah, more of the more. Exactly.
Well,
But
thank you
thank
so
you.
much. Yeah, and thanks for all the fabulous work you're doing with FND Help. I think, it's really important about patient advocacy and really raising your voice and letting everyone know this is an important issue. I think that's part of pushing the agenda forward. Yeah. Mhm.
Yeah. No, indeed. So thanks to everybody for participating with us, and thank you again, Kathrin. It's been
Great. Thank
wonderful.
you. Nice to meet
Thank you
you.
very much. All right.